Good morning, everyone. Welcome to the Orlando GI Journal Club. This is February 5th, 2025, 7 a.m. Eastern Standard Time. Welcome, everyone. Our first study is by Tange et al., published in the American Journal of Gastroenterology, and looking at older age as a worrisome feature in patients with IPMN. Intraductal papillary mucinous neoplasms, or IPMNs, are characterized by mucin-producing properties and a papillary growth pattern with a potential for malignant transformation. A better understanding of the risk factors for the incidence of pancreatic cancer could lead to more effective management of IPMNs with tailored surveillance intensity. Patient demographic characteristics have not been vigorously investigated in the context of pancreatic carcinogenesis among patients with IPMN undergoing long-term surveillance. And aging potentially exerts a multifaceted effect, and cohort studies have demonstrated aging-related risk increase in the general population in pancreatic cancer. The aim of the study is to examine the association of age at IPMN diagnosis and long-term incidence of pancreatic cancer. This is a prospective, single-center study conducted at the University of Tokyo in Japan. They included 3,142 patients with branch duct IPMNs and main duct IPMNs diagnosed between 2000 and 2021. They excluded patients with main duct IPMN with ductal diameter of 10 millimeters or greater because these patients are surgical candidates and should not be undergoing long-term surveillance. Pancreatic cancer diagnosis by EUSFNA was performed in 130 of the 3,142 patients. 64 patients from IPMN-derived carcinoma and 66 with concomitant ductal adenocarcinoma. The authors examined the association of age at IPMN diagnosis with incidence of pancreatic adenocarcinoma using a multivariable regression model, and in total, the study had 22,000 person-year follow-up. These are the baseline characteristics. A total of 3,142 patients with IPMN were included in the study. As you can see, the size of IPMNs were predominantly less than 10 millimeters or 10 to 19 millimeters in size at the time of diagnosis. Half of the patients had one IPMN, and 38% of patients had 2 to 5 IPMN at the time of diagnosis. 18% of the patients had diagnosis of diabetes at the time of diagnosis. 6.4% of patients were current smokers, 31% had history of smoking. The authors then stratify the patients according to their age, less than 55, 55 to 64, age 64 to 74, and 75 years or greater. And the biggest cohort were patients who were 65 to 74 years, followed by 75 or greater, and then 55 to 64 years in age. So what the study investigators did was look at the risk of pancreatic cancer among patients with IPMN, and then looking at the age at IPMN diagnosis to see if this was a significant factor in pancreatic cancer diagnosis. So the authors looked at the pancreatic cancer incidence overall, and they took patients aged 55 years or less than 55 years as the baseline, and then compared the risk of cancer development in patients 55 to 64 years, 65 to 74 years, and 75 years or greater. And as you can see, on multivariable analysis, which is the last column here, age 65 or to 75 years was a significant risk factor with hazard ratio of 2.56 with a 95% confidence interval, 1.1 to 5.98. And if you look at age group of 75 years or greater, on multivariable analysis, the hazard ratio for developing pancreatic cancer was 3.3, with 95% confidence interval of 1.4 to 7.83. When the authors looked at risk of IPMN-derived carcinoma and concomitant pancreatic adenocarcinoma, the risk, the hazard ratio is not statistically significant because the 95% confidence interval is less than 1. The lower limit is less than 1 for all of these age groups. However, I think this is probably due to the small number of patients out of the 3,000 patients who actually were diagnosed with pancreatic cancer, which was in total 130 patients. The authors then looked at the long-term risk of pancreatic cancer in IPMN according to age at IPMN diagnosis and presence of worrisome features. And this is really interesting, and I think this is a very useful table. So they took as baseline patients who were younger than 70 years and without worrisome features as the baseline. And then they looked at the risk of pancreatic cancer development according to the presence of worrisome features and age, 70 years or greater. And as you can see on multivariable analysis, if you have no worrisome features, but older than 70 years, then you are at an increased risk of developing pancreatic cancer with hazard ratio of 1.73, with 95% confidence interval from 1.01 to 2.97. Now, if you have worrisome features and older age group, 70 years or greater, the hazard ratio is the greatest of all, unsurprisingly, with hazard ratio of 2.86, 95% confidence interval of 1.66 to 4.94. The limitation of this study is that this is a single-center study, and they do acknowledge that there may be unmeasured confounding factors in the multivariate model. Also, importantly, we're looking at the age at the time that these patients were diagnosed with IPMN, but that doesn't necessarily correspond to the timing of IPMN development, but rather to the timing of imaging studies. So the take-home point from this study is that older patients with IPMN are at higher risk of developing pancreatic cancer during surveillance, and surgically fit elderly patients may be good candidates for surveillance aimed at reduction in pancreatic cancer-related deaths, and older age should be considered a risk factor with similar risk increases associated with the presence of worrisome features. Our next study is by Allegretti et al., published in Gastroenterology this month. This is looking at the safety and tolerability of CP101, which is a full-spectrum oral microbiome therapeutic for the prevention of recurrent C. diff. This is a phase 2 randomized trial. Recurrent C. diff, or Clostridius difficile infection, remains common, and human colonic microbiome provides colonization resistance against bacterial pathogens and plays a key role in pathogenesis of recurrent C. diff infection. The efficacy of full-spectrum oral microbiome therapeutic on prevention of C. diff infection is unknown. CP101 is a full-spectrum investigational oral lyophilized microbiome therapeutic designed to deliver a complete and functional microbiome to increase microbiome diversity and enhance colonization resistance for prevention of C. diff recurrence. The aim of this study was to determine the safety and efficacy of CP101 to restore a diverse microbiome and to prevent recurrent C. diff infection. This is a multi-center phase 2 randomized trial. It was a double-blind, placebo-controlled trial. Adults with recurrent C. diff infection, defined as one or more C. diff recurrence rates, recurrences that were diagnosed by PCR or toxin enzyme immunoassay were randomized in a 1-to-1 ratio to a single oral dose of CP101 or placebo, both after standard care of antibiotics. They had a 24-week follow-up. The primary outcome was proportion of patients without C. diff recurrence through week 8. 102 patients were randomized to CP101, 96 patients to placebo. The mean age in both groups were 65 and 66.5 years, respectively. In terms of the Charlson Morbidity Index, mean was 3.9. The proportion of patients with second or further recurrence comprised the majority of the patient cohort in this randomized trial, 70.7%. 61% of patients were diagnosed by PCR, and 37% of patients were diagnosed by toxin EIA-based testing. At study entry, the type of antibiotics the patients were on were oral vancomycin in 86%, oral fidaxomicin in 20%, and oral metronidazole in 3%. This is looking at the recurrence of C. diff infection. So if you look at the primary endpoint is proportion without C. diff infection recurrence at week 8, patients who were on standard of care with CP101 had 4.5% of patients without C. diff recurrence at week 8, compared to 61.5% on a placebo. And this was statistically significant with p-value of 0.0488. At week 24, 73.5% of patients in the CP101 group were without C. diff infection, compared to 9.4% of patients in the placebo group. And this also was statistically significant with p-value of 0.0347. Also, they looked at the time to the sustained clinical cure, so time in which the patient remained without C. diff infection up till week 24 using log rank test. And this was also significantly different between CP101 and placebo, with significantly high proportion of patients in the CP101 group remaining without C. diff infection, with p-value of 0.018. The adverse event rates were similar between the two groups. Subjects without any adverse events was 93% in the CP101 compared to 91.9% in the placebo. When looking at severe adverse events, rates were 10.6% in the CP101 group, 9.1% in the placebo group. And the most common types of adverse events included GI symptoms, diarrhea, abdominal pain, fecal urgency, abdominal distension, nausea. The limitation of this study is that the minority populations were underrepresented, and there were no patients with IBD included in the study. The take-home point from this randomized trial is that this CP101 was superior to placebo in reducing recurrent C. diff infection with safety profile similar to placebo. Our next study is by Amiot et al., published in Gut this month. This is looking at patients with acute severe ulcerative colitis who respond to IV steroids, and looking at top-down infliximab with azathioprine versus azathioprine alone in a randomized trial. Acute severe UC is a life-threatening exacerbation of ulcerative colitis with high risk of morbidity, and 15% of patients actually undergo colectomy. Intravenous steroids are the mainstay first-line medical therapy for acute severe ulcerative colitis, resulting in treatment response in 2/3 of patients. but currently there is lack of evidence to choose aminosalicylates, thiopurines, or advanced therapies in patients with acute severe UC responsive to IV steroids. The current recommendation is in Europe especially, is to use thiopurine maintenance therapy in thiopurine-naive patients with acute severe UC responsive to steroids. So this randomized trial was looking at the efficacy and safety of combining infliximab and thiopurine versus thiopurine alone in patients with acute severe ulcerative colitis responsive to steroids. This is a multi-center randomized trial conducted in 23 centers in France. This was an open-label study. Patients with acute severe ulcerative colitis admitted to the hospital who were both thiopurine and biologics naive, who then responded to IV steroids, were randomized to either infliximab and azathioprine and a 7-day steroid tapering scheme, or azathioprine alone with conventional standardized prolonged steroid tapering regime when prednisone is tapered off after several weeks gradual tapering regime. The primary endpoint was treatment failure at week 52, defined as the absence of steroid-free clinical remission, absence of endoscopic response, use of prohibited treatment for relapse, severe adverse events leading to treatment interruption, colectomy, or death. So I think one thing to notice about this randomized trial is that for an IBD trial, the sample size is quite small. 32 patients in the infliximab group, infliximab with azathioprine group versus azathioprine monotherapy. So 32 patients in each group. The mean age was 36.8 in the infliximab group, 40 years in the azathioprine only group. 40% of patients in the infliximab group, this was their first attack of UC. First attack of UC comprised 44% of the azathioprine monotherapy group. When looking at the total Mayo clinical scores, 9.6 in the infliximab group, 10.1 in the azathioprine group. CRP was 27 in combination group, 30 in the azathioprine monotherapy group. Looking at the primary endpoint of a proportion of patients who failed treatment at 52 weeks, this was 53% in the infliximab with azathioprine arm versus 81.5% in the azathioprine only arm. This was statistically significant with p-value of 0.029. And the odds ratio of treatment failure was 3.85 in the azathioprine only arm. So that means patients with on azathioprine only were up to nearly 4 times more likely to fail treatment. For secondary endpoints, they looked at steroid-free clinical remission, and endoscopic remission. So when looking at steroid-free clinical remission at the follow-up period of 14 and 52 weeks, in the combination group, it was 31.6 versus 13%. But when you're looking at the individual follow-up periods, at week 14 and week 52, the proportion of patients with steroid-free clinical remission was statistically significantly greater in the combo group versus the azathioprine-only group. When looking at clinical remission, at week 52, 52% of patients in the combination arm achieved clinical remission versus 26% in the azathioprine-only arm. This difference had a p-value of 0.04. When looking at endoscopic remission, however, there was no statistically significant difference between the two groups, although numerically, as you can see, it does appear to be greater in the combination group compared to azathioprine at 36% in the combination group versus 18.5% in the azathioprine arm at week 52, but p-value was only 0.15. For adverse events, there was no statistically significant difference between the two groups. The incidence of any adverse event was 80% in the infliximab with azathioprine arm versus 60% in the azathioprine monotherapy arm. When looking at the infection rates, it was 23% in the combination group, 7% in the azathioprine group. When looking at serious adverse events, it was 45% in the combination versus 37% in the azathioprine group. The limitation of this study is the small sample size, I think, primarily. The authors state that this recruitment for this study was difficult, and the study was partially conducted during the COVID pandemic, which also made recruitment difficult. And also this is an open label study. Obviously it's difficult to blind patients and investigators when the treatment regime is so different between the two groups, especially in regards to the steroid taper. So the take-home point from the study is that after response to acute a severe ulcerative colitis to IV steroid treatment, combining infliximab with azathioprine was superior to azathioprine alone for preventing treatment failure at week 52. So for a recap, older patients with IPMN were at higher risk of developing pancreatic cancer during surveillance. Surgically fit elderly patients may be good candidates for surveillance aimed at reduction of pancreatic cancer-related deaths, and older age should be considered a risk factor with similar risk increase associated with presence of worrisome features. CP101 was superior to placebo in reducing recurrent C. diff infection with safety profiles similar to placebo, and after response in patients with acute severe ulcerative colitis to IV steroid treatment, combining infliximab with azathioprine therapy was superior to azathioprine alone for preventing treatment failure at week 52. This concludes our journal club for this month. Our next monthly Orlando GI Journal Club is on March 5th, 2025. Thank you so much for joining us this morning. Please have a wonderful day, week, and month, and we will see you in March. Happy February. Thanks. Thank you, everyone. Bye.